The urinary bladder is a muscular sac in the pelvis, just above and behind the pubic bone. When empty, the bladder is about the size and shape of a pear. Common bladder disorders include cystitis, cystophthyitis, and bladder cancer. Bladder cancer is a malignant tumor caused by abnormal proliferation and differentiation of cells in the uropithelium, a specialized type of tissue that lines the inside of the urinary tract. It is one of the most common malignant tumors of the urinary system. It is the 7th most commonly occurring malignant tumor among men and is also common among women. Bladder cancer has been classified based on histology features: urothelial carcinoma of the bladder, squamous cell carcinoma of the bladder, and adenocarcinoma of the bladder. The tumors can be further categorized by whether it infiltrates the muscular layer of the bladder. Non-muscle invasive bladder cancer, NMIBC, accounts for about 75% of bladder tumors. Muscle invasive bladder cancer, MIBC, accounts for the remaining 25%. Two major risk factors that could lead to bladder cancer are smoking and long-term exposure to industrial chemical products. Other factors include long-term chronic inflammatory irritation in the bladder, long-term foreign body irritation, age, genetics, and genetic abnormalities. Hematuria is one of the most common symptoms of bladder cancer. At the same time, it may be accompanied by urinary frequency, urgency, dysuria, etc. Bladder cancer screening includes physical examination, auxiliary tests, cystoscopy, and biopsy are the most reliable methods to diagnose bladder cancer. They are also the main methods for post-operative recurrence monitoring. TURBT is the preferred treatment for NMIBC, while the intravesical instillation therapy may be used depending on the risk of relapse. The relapse rate among patients who have received TURBT is high, at 24 to 84% within 5 years, with some patients progressing to MIBC. Post-operative adjuvant intravesical instillation therapy comprised of bladder chemotherapy, perfusion, and Basal-Calmette-Guerin (BCG) perfusion. There is no feasible second-line treatment option after the failure of intravesical instillation drugs, and there is an urgent need for drugs with new mechanisms of action to prevent or delay the need of total cystectomy. Patients show poor tolerance with intravesical instillation drugs. Bladder chemotherapy perfusion and BCG perfusion can cause urethral irritation symptoms, and the incidence of adverse events such as hematuria and pain are too high for some patients. Intravesical instillation is an invasive method of drug delivery with a long dosing cycle and poor patient compliance. Patients, therefore, are in urgent need of new therapeutic drugs with significant efficacy, high safety, and easy delivery. Among the surgical-based comprehensive therapies for MIBC, squamous cell carcinoma, adenocarcinoma, and umbilical ureterocarcinoma, radical cystectomy is the preferred choice, while partial cystectomy is an option for some patients. For patients who can tolerate radical cystectomy, the GC regimen, gemcitabine in combination with cisplatin, is commonly used for neoadjuvant therapy. For patients who are cisplatin ineligible, there is still a need for neoadjuvant therapies that could provide the survival benefit. There is an unmet medical need for new and effective agents with minimal side effects for neoadjuvant therapy. Metastatic bladder cancer is primarily treated with systemic chemotherapy, and palliative surgery and radiotherapy may be applied to relieve symptoms.